Hi, this is Steve Fordham, consultant in the emergency department at the Royal Devon and Exeter Hospital. This is a short podcast summary of the clinical evidence for COVID-19 so far. The brief background to this is from a core medical training session I delivered about 10 days ago, and then having chatted to teams on the shop floor last week, there seems to be the appetite for a brief summary of the published clinical evidence thus far. So here we go. So looking through the open access records of some of the big journals since January 2020, the New England Journal of Medicine, BMJ and the Lancet, there are a number of retrospective cohort studies that have been published. The data collection for these studies occurred over the month of January, and these are hospitalised patients. The median age in these groups is between 41 and 56, and a point to hold for later is that in the Lancet paper, for the time from onset of symptoms to admission to hospital had a median of 11 days. It's very difficult to give an accurate estimate of mortality based on this data, but it's really important to remember that over 80% of people who are infected will have a mild course of illness. It's fairly clear that most patients will present with constitutional symptoms and lower respiratory symptoms, so fever and cough. Between 5 and 10% of patients may present with diarrhea and vomiting or gastrointestinal symptoms. I'm not going to say anything about bloods because I'm not sure there's enough concrete evidence to suggest that bloods will change our emergency management of these patients. Now, the next two slides are the most important. The diagnosis, we know that the reported sensitivity of swabbing is between 30 and 90%. When we look at the imaging data, then upwards of half of these patients will have an abnormal plain chest radiograph, and even more so if we go on to do a chest CT. Typical findings seem to be patchy ground glass opacities and bilateral pulmonary infiltrates. I guess the other thing is that it seems that pleural effusion is uncommon, and COVID-19 doesn't appear to cause masses, cavitation or lymphadenopathy. And then the final slide is really important to focus on. So the clinical course of this illness seems to be that between day 1 and day 7, the patients will have a fever and cough. It seems to be that after this time is when we are looking for the onset of shortness of breath and increasing oxygen requirement, and that the potential for deterioration then increases. You remember from the early slide in the Lancet paper, the median time from onset of symptoms to hospital presentation was 11 days. So these patients are presenting to hospital once their shortness of breath and oxygen requirement causes them to do so. So how are we going to treat these patients? Well, first thing is to keep safe and follow the local PPE guidelines. And secondly, I think we've got to keep things simple. There's a COVID clinical guideline on the hub, and we're really focusing on oxygenation, good hydration, and escalating as appropriate. As you can see, there are a large number of treatments that have been used in these patients across the studies, and none of them are currently evidence-based, although this will probably change over the coming days, weeks, and months. What about kids, I hear you ask? Well, I would direct you to the Don't Forget the Bubbles. The news generally seems to be good in that children will get a mild form of the illness in the majority of cases. So thanks for listening. I hope this short summary has been useful. Please remember it will be out of date very soon. We work for a great trust, so remember we stay calm, look after each other and move forwards as a team.